My last slide before we get started is just a reminder that this information is copyrighted, and this presentation and the corresponding slides may not be recorded, copied, distributed, or otherwise used without authorization. So having gone through my requisite slides, I'm really excited to have you all here and excited to have Dr. Joe Muniak with us as well. Dr. Joe is going to talk to us about feeding and food safety in managed care facilities. And Joe, with that, I'm going to stop sharing my screen if I can get this window out of the way. If you want to go ahead, share your screen, turn on your camera. We're all excited to have you here with us. All right, Joe, I see your screens. I don't see you just yet.
All right, Jesse, can you hear me?
I can. There we are.
All right. There you go.
I thought maybe I lost you, Joe.
No, I'm here. Yeah, thank you for that intro, Jesse. I really appreciate it. I really am truly happy to be here and to do this brief presentation with you folks, provide some of the information I've gained over the years in the way of knowledge related to feeding in different facilities. So I'll start out talking a little bit about myself. So I am an occupational therapist by background and healthcare administration expert with Robson Forensic since last year. I actively work as an adjunct professor in the College of Rehabilitation Sciences at Thomas Jefferson University here in Philadelphia. I've done that for well over the better part of a decade. And I also currently treat in home care occupational therapy. I was formerly the Director of Therapy Services for the University of Pennsylvania Health System, which included all Philadelphia inpatient hospitals and spanned inpatient rehab, acute care, skilled nursing facilities, long-term acute care hospitals, and outpatient facilities. So this role encompassed the direct oversight of approximately 350 employees and required collaboration decision-making with leadership across numerous disciplines. I'm a standard of care expert as it relates to supervision, policy and procedures, care plan analysis, safety, and risk management. As far as feeding goes, I have directly managed speech language pathologists, as well as provided oversight of interdisciplinary team members responsible for implementing safe feeding programs. This includes nurses, nursing assistants, other therapists, additional ancillary staff. So they were all under my purview. Additionally, I have designed, managed, and maintained multiple inpatient-based feeding programs, including ones specifically designed for the neurological, spinal cord, and brain injury populations. So this might sound a little funny. My colleagues get a kick out of this, but feeding is a passion of mine as far as within these institutional settings. And it's an area commonly focused upon by occupational therapists as well, because it is an activity of daily living. So in healthcare and in promoting patients' functions and recovery, giving someone the ability to eat and drink is a fantastic feeling. And very selfishly, it's met with a lot of gratitude from the patients and families when you are able to find a way for them to be able to eat and drink. So oftentimes these folks have lost so much. So again, if you're able to help them regain this basic function, it really means the world to them. Okay, so why feeding today? How does this relate to your cases and what we see? Why present on this webinar? So simply put, everyone needs nutritional intake. It's commonly through eating and drinking, but when speaking about care facilities, this can also include nutrition delivered through feeding tubes. The prevalence of dysphagia, or that is the difficulty or discomfort in swallowing as a symptom of a disease, is in the community dwelling older adults, for those aged 50 and older, is estimated to be somewhere between 15 and 22%. So for those adults over 50 that have some sort of issues with feeding or swallowing, that's a big percentage to have that happen. Usually when you're in the hospital, one of the first questions people ask is, when can I eat or when can I drink? So it's an extremely important and addressed issue in those facilities. The at-risk population often have specific feeding needs, including consistencies, assistance, supervision needs. And unfortunately, if these needs are not met or they're missed, it can lead to some pretty to potentially catastrophic events, some really bad outcomes. So over the next 15 minutes or so, we're going to talk about the following high-level topics related to feeding. These will include some examples of areas that where, when breakdown occurs, can lead to these negative patient outcomes. What are some of the negative outcomes that we're going to see? What are components of a comprehensive assessment for feeding that should occur? We're going to provide some examples of interventions implemented to meet these needs identified during the assessment. And we're going to look at some considerations around safety, supervision, and auditing, which help meet the standard of care for feeding programs. And lastly, we'll touch on the interdisciplinary team members involved in a successful feeding program. So in this slide, you're going to see some common areas of breakdown or where there's deviations from the standard of care. So with assessment and testing, when things are not identified and or completed in a timely manner, this can lead to some negative outcomes. Appropriate supervision. So supervision can be provided in varying degrees, and we will touch on this a little bit later. But simply put, when it's not in place or followed through on, again, negative outcomes. Documentation. So there's a couple areas here. This includes not only documentation of the care plan, but documentation of when interventions were implemented, how they were implemented, and the response of the individual. So coming up again, we'll touch a bit on documentation. Education. So the competencies of the staff, and that they receive this continued education, and this education needs to be recorded and has to be shown that the information was not only received by the staff, but that they comprehended it and demonstrated its use. Auditing and performance improvement. This is a crucial piece to meeting the continuum of care model. And oftentimes can be overlooked, but simply it means the process doesn't end, okay? It's cyclical. The needs of the patient and how they respond to them, it's a constant process, and it needs to be reflected that way. And then policies and procedures. So this isn't simply what we would think of as if policies and procedures were not in place, but are they being followed? And are they being followed appropriately? And do we have the correct policies and procedures in place? Just because a place has policies and procedures doesn't necessarily mean they are the right ones. So when there is a breakdown or a deviation from the standard of care, some of the following can occur, okay? And this is just a small sample size, but some of the common ones that we see. So aspiration. That's when food, drink, or foreign objects are breathed into the lungs, okay? And then most commonly that leads to pneumonia. We oftentimes call this aspiration pneumonia. You can kind of think of this as when food goes down the wrong pipe, you know, and healthy people were able to manage that, usually with a pretty violent coughing fit. But your folks that don't have that ability or are a little more at risk, this could be a big deal. And then pneumonia, as we know, is the inflammation, swelling of the lungs and the large airways. I think we're all familiar with pneumonia. And that can lead to, especially in your frail elderly or at-risk populations, some really bad sicknesses and terrible outcomes there. So choking or airway obstruction, we all know what that is, right? You get kind of something stuck in there, and that could be, again, a real negative outcome of the care plan not being followed and some of these other steps not in place. And then asphyxiation, that's the process of being deprived oxygen, and that can come from many reasons, but of course from choking, or if there's airway obstruction, you're going to have asphyxiation. So scalding, again, when food's not appropriately monitored, this can occur. whether, we know what temperatures are coming out and how it's done, but not only that aspect, but you also want to look at what adaptive equipment is being used to help these individuals eat and drink. In our casework, we oftentimes see, for lack of a better word, they rig up some sort of mechanism in order for people to drink, and they end up burning themselves. Occupational therapists have a real pivotal role looking at adaptive feeding equipment, and if these things aren't implemented or utilized appropriately, someone can get hurt, which includes being burned. And then malnutrition and dehydration. All right, when there's a lack of appropriate intake, we know this can occur, and it can be due to the inappropriate assistance or the time needed for assistance. I think oftentimes we see someone needing a lot of time to complete feeding, and facilities don't have the plan in place or the staff in place to sit with an individual for that amount of time to make sure they have the appropriate nutrition and food, solid and liquid intake. And again, kind of goes back a little bit to documentation. If the documentation isn't there, you want to be able to track how this person's doing with intake. And this is another method that if not done correctly, could lead to a bad outcome. These things need to be documented. Okay, we're going to move on to examples of how assessments should be completed by care providers to determine the person's feeding needs and develop an effective plan of care. So evaluating feeding needs is a skilled service. It can be completed by speech therapists or speech language pathologists, SLPs. It could be completed by occupational therapists, OTs, and or the nursing staff. And in some cases, managerial staff, nutritional staff, and of course, physicians, they're all part of this skilled assessment, evaluation of the person's feeding needs. However, whoever is doing the evaluation, that person should have the appropriate training and experience and documentation to indicate that they have received and are able to do this. A few examples of components within this evaluation are setup, supervision, patient's positioning, the assistance level needed, and then we've mentioned this and we'll mention it again, the consistency levels that are there. So oftentimes, speaking of consistency and particle size, the first step is providing a safe nutritional assessment is to have a well-rounded eval, which tends to include this video imaging studies. Okay, so that is the MBS or modified barium swallows, and then FEES or fibro-optic endoscopic evaluations of swallowing. These are probably two of the most common that you'll see. They are completed by specially trained speech language pathologists and physicians, and it often requires a send out to another facility and coordination of multi-member teams. So this should be identified and initiated in a timely manner in order to get this done so the patient can start eating and drinking appropriately. With this, we're often looking to avoid silent aspiration. As we mentioned about aspiration that can lead to pneumonia, silent aspiration tends to happen with a lack of coughing, or the individual themselves do not even know that it's going down the wrong pipe and that the food went down into the trachea. So that's what these studies will tell us is with the imaging piece. Additional areas to consider in conjunction with what's gleaned from the imaging studies in regards to the consistencies of particle size are people's alertness level and their cognitive abilities. These areas also require trained care providers and require constant reevaluation. So an individual's alertness level can be impacted by many factors. Two common ones are, they're listed here, the time of day and the effects of medication. And these two don't operate independently. They are interdependent oftentimes as far as the medication's impact on the person depending on that time of day. So alertness level can change with the time of day. Someone can be better with one meal versus the other. Sundowning, many of us have heard of in the evenings for some populations, can have a big impact on how they do with their PM meals as opposed to their AM meals. And then medications can, like we said, can have an impact on these individuals and can change over time. Medications need to be looked at and communicated with the interdisciplinary team. So going on to cognitive screening here, global cognitive screens give a comprehensive picture of the individual's attention, problem solving, and communication abilities. These are all components of safe feeding. These factors are especially important in determining the person's supervision and assistance levels, which we'll talk about in a little bit. But that's where it really ties in their global cognitive abilities with really how much supervision and assist you should be giving the individual. Okay. So we talked about components of the assessment with feeding, and now we're going to touch on some of the interventions implemented for a safe and effective feeding care plan. So anything that was evaluated now should become part of the care plan. That's a big piece that sometimes can be missing. Even though you evaluate it and look at it, you need to incorporate it into the care plan. Looking at this, patient positioning. So simply put, think about it. You wouldn't eat or drink when you're laying flat. I think all of us maybe in a moment of laziness, when you're binge watching something, have been laying on the couch and try to get that sip in or that bite in without really sitting up as much as you should, and we all know the outcome of that. So it's a silly example, but it's even more important with this population to make sure that they're upright and out of bed. I won't bore you with the different stages of swallowing, but the pharyngeal phase and the esophageal phase, any of these passive ones outside of the oral phase with swallowing, you need gravity. Gravity helps you get that food down, especially with this population if they have any issues with feeding. So they should be upright. The head of the bed needs to be up as well as it can. Ideally, you're at 90 degrees when you're talking about that. And then we touched on tube feeds. Tube feeding does have a standard where the head of bed has to be 30 degrees or more when folks are getting tube feeds. And quite simply, if they're too flat, they will aspirate. You're pumping that food in, it will come back up and they will aspirate on that. It's a lot easier said than done to keep someone's head of bed at 30 degrees. And this is something we definitely look at in our investigations. People can slide down, and they often do. Just because you set the bed at 30 degrees and walked away doesn't mean the person's going to shimmy or slide down some, and then all of a sudden you're not at that 30 degrees. So that requires some monitoring and documentation on our part. Adaptive equipment. So I mentioned earlier about some modified drinking devices, and we have modified equipment for all sorts of issues. When there's visual considerations and folks might be missing one side of their environment or the other, or one side of their plate, we can quite simply move things into that visual field and they can access it more. When people have hemiparesis or weakness on one side of the body, we might need them to use plate guards, weighted utensils, some of these types of devices in order to get the proper nutritional intake. Two, probably the other biggest interventions that we use that are in our wheelhouse to keep patients safe and sufficiently nourished are supervision and assistance. So these are the ones, you can see the examples here. With supervision and assistance, it's not only important to determine the correct level and amount of supervision, but most importantly, we need to implement this, and it needs to be kept up with, consistent, and documented as such. Cueing are two examples. There's different levels and types of cueing. So there's verbal cueing, letting people know when to chew, when to swallow, that sort of thing. There's tactile cueing. You can actually help someone with a swallow assist by stimulating certain areas, or you might have to help them, remind them to use their hand, or just get them started with that bite, and they'll follow through. Then there's different one-to-one feeding needs. And again, this runs the whole gamut of levels and can be everything from, reminding the person, hand over hand assist for every bite or every drink. And it can go all the way up to total assistance. And that's where someone either needs to be fed and or could be looking at tube feeding. both of which require a lot of monitoring and a lot of time, especially on the care staff that are helping these folks. And lastly, we'll touch on, I think, what most people think of when they think of modified diets and feeding, and that's the consistencies and the particle size of foods. So that has to do with the thickness, the cohesiveness, and the stickiness, the hardness, and the separability. So these are all different factors that we need to consider. I wanted to shoot up here a quick graphic. We don't have to go into detail here. This is the International Dysphagia Diet Standard Initiative. To put it shortly, introduced, really should have gone into effect October of 2021 for most facilities. But this is your new framework for when you used to hear liquid thick or honey thick, those sort of descriptors. This is what we then moved towards, and a lot of accrediting bodies, the Academy of Nutritional and Diabetics, and the American Speech Language Hearing Association, they came together to make these. So you're going to see hospitals, and you might see documentation referencing this IDDSI framework. And I just wanted to kind of flash that up there so you could see special attention to number 4 and 3. With what we knew as pureed and how that equates to drinks, so food versus liquid, and in the extremely thick category being almost the same as pureed, and liquidized the same as moderately thick when you talk about drinks. Components of a successful feeding care plan should consider these factors as well. So we're going to talk about a few of those here. So communal dining. Communal dining has its pros and cons. In some cases, an individual might not be successful in a communal dining setting because of the distractions. And then again, from a staffing standpoint, or to be able to keep eyes on enough of the population, communal dining might be where a person is required to eat in order for safety and to make sure they're not choking or pacing themselves properly. Documentation, we mentioned this prior, but extremely important here. So you want to make sure that all the recommendations are made, those appropriate recommendations are in the plan of care, and all those things are present in the documentation and easily accessible to all care staff that need to get to this information. It's no good if something's documented in the system that says, Mrs. Smith cannot have thin liquids, but you have nursing assistant staffs that think they're doing the right thing. Miss Smith asks for something to drink, and they grab her, a big old cup of water. Again, if it's in there, it still needs to be easily accessible. And then, of course, people need to implement what is in there and consistently go with that. Visual inspections, this should occur with every meal. You should observe the person too, and that should be recorded. And then also the food. Food can congeal over time if it was sitting out, that sort of thing. So that should occur. You should look for signs of aspiration. We mentioned silent aspiration, but there's definitely other signs of aspiration. And that most obvious one is coughing after certain bites. But you can also do what we call the wet voice test, have someone talk and look at the quality of their voice as they're doing that. And then you can look at someone's pulse oximetry. So you look at the amount of oxygen in their blood and make sure nothing's going on there. And then pocketing inspection. This is really a big one with the stroke and neurological population. Folks tend to pocket food, and you'd be surprised if they can fit in there. Sometimes you go and check that out. They're truly like a squirrel. But that has to do obviously with awareness, sensational issues, and those things related to the disease or the injury. But you want to be aware of that. Definitely folks can have those things pocketed, go back to their room, and you could have a choking incident an hour later if food is left in the mouth like that. We mentioned coughing, pretty obvious one. You want to make sure that you monitor for this. This is a big sign. Make sure you convey this to the interdisciplinary team so that your trained professionals can look into it. Appropriate delivery. When you really do investigations with facilities, you think about the chain of what can happen here. You have assessments being done. You have a recommended particle size. Let's say it's chopped. Now your food staff have to take that order. That order has to get to the kitchen. That food has to be prepared by the chef appropriately. That food then has to get back up to the floor. It has to get to the appropriate person. It has to still have that on there, the tray, the appropriate food on the tray. And then if certain supervision needs were made, you can't drop the tray in front of the individual. If they do need some sort of supervision or assistance, they're going to start eating. So the delivery system itself is where a lot can go wrong, from ordering to preparing to delivery. So you want to look at those systems during investigations, and then how those systems are communicated. So we mentioned the delivery pathway, but how our facilities or other places utilizing EMR, or electronic medical records, is becoming more and more popular. And oftentimes this will give you a good investigative trail to look for. And then I mentioned before about the cyclical nature of this. You always want to be reevaluating and looking to improve with someone's individual plan. Some of the team members that are part of these safe beating programs. So we mentioned speech language pathologists and occupational therapists. There's registered dietitians. There's food service managers, cooks in the kitchen, the line staff, the clinical nutrition managers, all of the frontline staff, and then of course physicians. So you can see feeding really does encompass the multidisciplinary team, and it's not just one area here. I will say, as part of being a part of senior leadership, this was an area we looked at as a hospital administrator. It encompassed oversight of and collaboration with all of these disciplines that are listed here. We wanted, during our investigations, was the event preventable or not? What was the root cause analysis? Was the standard of care met? These are just a few examples of areas that we would look at, and I have looked at during our investigations with the process. So with that, I thank everyone for their time. Jesse, I don't think I ran over too bad.
Timing wise, Joe, I think you did that exactly perfectly. It's pretty clear to me that the food service aspect is a little bit more complicated than at my kids' elementary school, for example.
Yes.
We did have a question come in throughout the course of the program. If there are any more, please be sure to get into that Zoom interface and type that in as we go. So, Joe, the question that we have was involving that IDD-SI framework, and it was about distinguishing between the slightly thick versus mildly or moderately thick, and what that actually means in the field, and how professionals go about distinguishing one category from the other.
Sure. So I didn't include it in this presentation, but there are a lot of tests that can be done, drip tests, spoon tests, where they give you good descriptors of you need to test the liquid and see how quickly the viscosity changes, or how quickly it looks like another substance. So, your honey thick, you would think of honey and you want it to run off that way. Because many of these things, when you talk about soups even, or even just any liquids, think of water, there's packets, there's different things you can add to change these consistencies, and they give you suggestions, blank 1 packet for 8 ounces, let's say. In the real world and in hospitals, it's not always easy. You're not sure if it's a 12-ounce cup or a 16-ounce cup. So any staff dealing with that have to work with different consistencies or particle sizes should have that training. There's a test with a fork, for example, that you can see how moist and bite-sized it is, and you want to see if it can get through the prongs of the fork, right? And that's going to tell you whether it's a little too congealed, or it's too it bunches up. So there are many tests like that, and again, we're in a phase of transition, meaning some of the descriptors of nectar thick, honey thick, look at those things are not here, as you can see, but there are parallels to the two. And as long as folks are educated on how to test and how to produce those different viscosities, then you're good, you're covered. It all comes back to the education and the testing and making sure your folks know how to look for those things.
All right, well, that's wonderful. Dr. Muniak, that is all we have for today. I do appreciate you being with us here, of course. And if anybody had any questions that they just didn't want to air on the webinar, you can always email us at inquiries@robsonforensic.com, or you can contact Dr. Muniak directly at jmuniak@robsonforensic.com. Joe, thank you so much. I know you've got a lot going on. I'll talk to you soon.
Thank you. Thanks, everyone.